Today we are going to continue talking about mood disorders, starting with, we were in the middle of talking about major depressive disorder, and we'll talk about some seasonal affective disorder or major depressive disorder that changes depending on the seasons, and then bipolar disorder as well. If we look at the genetics, people who have early onset major depressive disorder, so this is people who get depression before the age of 30, they have a high probability of other relatives with depression, anxiety disorders, ADHD, substance abuse disorders, obsessive compulsive disorder, and irritable bowel syndrome. If we look at late onset, so people who are getting depression after the age of about 45 or 50 years old, they have a high probability of relatives with circulatory problems. So there are genetics involved. There is no simple, I'm going to point to a gene and say this is a predisposition. It's not that simple. And the degree of heritability is a moderate degree of heritability. If we look at the concordance rates for identical twins, it's 2 times higher than for fraternal twins, which suggests heritability. But we know several genes are involved and no one gene has a large effect. The gene that has been examined the most and appears to have the strongest association with major depressive disorder is called the RORA gene. I can't remember if I mentioned this in the wake-sleep cycles or not, but this is the gene involved with the control of circadian rhythms, which is why we see those sleep disorders as part of depression. And sleep disorders, if I have depression, I have a sleep disorder. That doesn't necessarily mean I have this gene, but that all is very highly correlated as well. Another gene that has been examined, this is another one of those studies by Avshalom Caspi. I know I don't say his first name right, but and this, I think this study is one that has not been replicated, but it's in the book, and I'm going to talk about it anyway, but where we see this real interaction between genetics and environment is the serotonin transporter protein, or the gene controlling that serotonin transporter protein. And we can receive either a short type or a long type from the 2 alleles from each of our parents. And the short form appears to increase emotional reactivity, whether it's good or bad. And what we see is this, along the x-axis, this measure of the number of stressful life events, and then in A it is the probability of having a major depressive episode, and in B we're going to look at the likelihood of some kind of suicide attempt or suicide ideation. And regardless of whether or not we have short serotonin alleles or long serotonin alleles, if we have 1, 2, I'm going to say even 3 stressful life events, that is not so related to whether or not we're going to see depression and suicidal ideation or suicide attempts. But once we get up to maybe 3, but really 4, once we get into 4 stressful life events, then we see this real distinction between whether or not we get 2 long alleles, a short and a long, and if we got 2 of the short alleles, then we are fairly likely to have depression or suicidal ideation and suicide attempts. And I usually make the very not so funny joke that I obviously had 2 short alleles. I did have a grandfather on my mother's side who had PTSD, which we also see related to low levels of serotonin. My mom and I both like to keep moving, and that is going to release some serotonin. And when I get really still, my mom just does not stay still, but when I get really still and I'm laying around, I get very fatigued and tired and kind of depressed. And I usually also, I know I've talked about tryptophan at least once, and since I'm a vegetarian, making sure that I get tryptophan in my diet and not too much of the tyrosine and the things that are going to bully their way past the blood-brain barrier and create dopamine, and not let tryptophan, which is going to help me create serotonin, pass. Even that can lead me to an episode of depression. So it's a good thing to keep in mind. It's not just your genes, it's also environment. but you are much more vulnerable if, in this case, if you have the two short serotonin genes for this example, but we also just saw the ROR gene as well. Other biological influences that we see. So one is influences due to hormones. There have been a few studies linking hormones to depression, cortisol, and stress. So we actually talked about this a little tiny bit when we talked about sleep-wake cycles for those people who were traveling across time zones, that they were constantly releasing more cortisol, and that led to smaller hippocampi. And again, I think I've said this now a couple times, but I have to say it in the major depressive disorder section, and I will talk about the hippocampus quite a bit. But when we're looking at what's a good treatment for depression, it looks like what helps the most is something that creates neurogenesis in the hippocampus and the neurotrophins, the brain-derived neurotrophic factor in the hippocampus, that allows the hippocampus to basically not shrink and get smaller. And so those flight attendants who were crossing time zones a great deal, they had smaller hippocampi, and that is related to depression, although again in those correlational kind of ways. We also see postpartum depression, where about 20% of women have some kind of postpartum depression after having a baby, and the assumption is some of this, at least, is due to hormonal fluctuations. I mean, a lot about your body and your life have changed since you were pregnant, but there are these pretty strong hormonal fluctuations in there as well. They've also done a study where they caused a drug-induced drop in estradiol and progesterone, and women who had a history of postpartum, they showed new symptoms of depression. So we do see we appear to have some relationship between our estrogens and our depression symptoms. We also see men with lower testosterone are more likely to be depressed than men with higher testosterone. Another relationship that we see with major depressive disorder and what's happening in the brain is the relationship with these abnormalities in hemispheric dominance. And so looking at the more frontal regions of the brain, if we have more left prefrontal activity or activity in the frontal lobes, we see people tend to have more positive, happy moods. We did talk about this before as the behavioral activation system. If people have more activity in the right, really the frontal and anterior temporal lobes, so the frontal part of the brain, we tend to see more depression. We did talk about this before as the behavioral inhibition system, and so I don't want to repeat too much because we did talk about these in the emotion chapter as well. But just so I put this together with the depression topic, that it's really that we have that depression that we see with the right prefrontal activity, that's really that we have lower activity in that left frontal area. That it's right prefrontal activity as kind of a comparison to left prefrontal activity. So we have started talking about the biology of what we know about the biology and genetics and everything behind major depressive disorder. And we have not yet talked about neurotransmitters, which is an important thing to discuss when talking about, I'm just going to start calling it depression as I often do. So one of the things that's, I think I've mentioned this before in this class, but I think I should state clearly here, as your author does, that usually what happens is we find a medication that works, and then we go and try to figure out how it works, and then we realize that because the medication is influencing these receptors in our brain, then we go and figure out what are the endogenous chemicals in the brain that are having the same effect. And I'm going to start by talking about tricyclics, and this is not going completely in historical order, which I tend to like to do. The tricyclics did come around pretty early. So imipramine that blocks the reabsorption of serotonin, dopamine, and norepinephrine. So it is the one of those reuptake inhibitors, but it is for 3 different neurotransmitters: serotonin, dopamine, and norepinephrine. And that was what we saw it working on, even though it works on monoamines. Okay, and those monoamines include epinephrine and histamine. And we also see an influence on acetylcholine of tricyclics. They're kind of a messy drug, and if I haven't said this before, I think I have, with hopefully with smoking cigarettes with tobacco, that it's a very messy drug. And one of the things we try to do with our drugs when we're trying to help somebody, so that we're trying to get these prescribed drugs that are helpful to someone, we try to get them as clean as possible, because that means fewer side effects. And so tricyclics also block histamine receptors, which means we're going to be sleepy. It blocks acetylcholine receptors, so we end up having dry mouth. And it blocks certain sodium channels, so we have heart irregularities as well. The difficulty urinating, that's also due to acetylcholine receptors being blocked. And so we have other side effects as well. They're a messy drug. We try not to use them. People try not to use them. But if somebody is pretty treatment resistant with other antidepressants that we're going to look at, they might try them on tricyclics. And tricyclics came around before the Prozac and Paxil and Wellbutrin and all of those ones that we tend to know these days. So they were here earlier in history. Usually the first line of defense is a selective serotonin reuptake inhibitor, and that is because this is a clean drug where the only thing we're really influencing is serotonin. And again, what we're doing is we're basically freezing that reuptake inhibitor so that serotonin kind of, I'm not going to say this quite the way it works in the brain, but it kind of bounces off, and instead of being pulled into the presynaptic neuron, so that serotonin is staying in the synaptic cleft for longer to influence the postsynaptic neuron. Some of the most common ones are fluoxetine and paroxetine, what we know as Prozac and Paxil. And they have fewer side effects because of this, how clean the drug is. If SSRIs don't work, and I've mentioned SSRIs for a number of things now, but especially depression or major depressive disorder, they might try a serotonin norepinephrine reuptake inhibitor, or an SNRI, so Cymbalta or Effexor. Those have come along a bit later, and they block the reuptake of both serotonin and norepinephrine. And then they've also got now these atypical antidepressants like bupropion, or what's known as Wellbutrin. This blocks dopamine reuptake and to some extent norepinephrine, so working on the catecholamines and not the whole group of monoamines, and so serotonin is not included in that. For people who this works for whom this works, I'll say that correctly, syntactically, hopefully a little bit. It really is a different way of treating depression, and it suggests that something different is going on with people for whom Wellbutrin works and those other ones don't work. And usually, again, they start with the SSRIs, not always, but that's what they typically do. And then if the SSRIs and the SNRIs don't work, they might try the atypical antidepressants or something like Wellbutrin. If we look back historically, one of the very first antidepressant drugs were monoamine oxidase inhibitors. So we've talked now a couple of times about monoamine oxidase, the enzymes that are in the terminal buttons that are breaking up the excess monoamines. And so that includes serotonin, norepinephrine, dopamine, and then the epinephrine and histamine, but really it's those, the serotonin, dopamine, and norepinephrine are kind of the important ones for depression. And those are metabolizing those into inactive forms, because when we have an excess, what monoamine oxidase is just going in and taking those apart with the assumption that we're going to have some excess. And so the inhibitors, what the MAOIs do, or monoamine oxidase inhibitors do, that's the drug, they inhibit that enzyme. And so now we have more of those, all of those monoamines available to affect the postsynaptic neuron. And that sounds like a really good thing, but monoamine oxidase, it is in other parts of the body, and it is helping us metabolize other things in other areas of the body. And so now people who take MAOIs have to avoid foods that contain tyramine. So they are not allowed to eat things like, the only ones I remember are the ones that I would horribly, horribly miss, which is chocolate and red wine. But there are other things that if they eat them, this can actually cause high enough blood pressure that it can kill them. So we try, or psychiatrists, people try to not use MAOIs unless really nothing else is working. This was what they used more back in the 1950s, but this has been used less and less frequently as we have gotten better, cleaner drugs that aren't influencing this enzyme, which also has, again, is metabolizing other things. Your author also does talk briefly about St. John's wort, so this herb that you can get over the counter, or really in health food stores and in many places. It is marketed as a nutritional supplement, and so it's not regulated in any way by the FDA. It's not going to be prescribed by your psychiatrist or by, if you're going to a general practitioner who is prescribing you something because you don't want to see a psychiatrist, that this is not going to ever be prescribed by a doctor. But you can try St. John's wort, and I've had friends try St. John's wort. Its effectiveness is about the same as a standard antidepressant, or at least what we see in the percentage of people who are helped by St. John's wort. The percentage is about the same as antidepressants. However, St. John's wort does increase the effectiveness of an enzyme in the liver that then decreases the effectiveness of other medications. And so if you are a person who is on other medications, whatever those medications may be, whether they're other antidepressants or medications for your physical health in some way, you really want to consult a physician before deciding to take St. John's wort. So I have this question here under antidepressant drugs. Is any single drug producing any different effects than others when we're looking at the overall effect of what's happening in the brain, and when we're looking at just the percentage of people who are helped? It really does appear that certain antidepressant drugs help some people and other antidepressant drugs help other people, which means something slightly different is going on with those people. And what that is, I don't know. And I don't know how many of the psychiatrists and general practitioners really know. I know that when I went to a psychiatrist, he had me and two of my friends on different antidepressant drugs to start with. I started on Paxil, and a friend of mine started on Prozac, and another friend of mine was on tricyclics. I don't think that was the first thing he tried, but that was what she ended up being on. And it looked like he was asking specific questions about our sleep problems, but this is what psychiatrists do. He asked particular questions about the sleep problems, the type of depression, our fatigue, how we were eating, and what kinds of anxiety we might be experiencing, whether it was generalized anxiety or social anxiety or no anxiety at all. And he put us on different medications based on what he thought was going to help us the most. And I thought he did a pretty good job. But if you notice, Prozac and Paxil are in the same class of drugs. They're both SSRIs. And so why me on one and my friend on the other, I don't completely know. She did not have the same kind of anxiety symptoms that I had, but that's just what he ended up doing. We don't really seem to know whether a single drug is having a different effect than other drugs or how they are affecting people, except what we do know is that antidepressant drugs are producing their effects on neurotransmitters in the synapse, and that occurs within minutes to hours, depending on the drug. So that change is happening very quickly, but if you've ever been put on an antidepressant, it takes, it says in the book, 2 or more weeks. It takes more than 2 weeks. The first time you're put on an antidepressant, it takes a few weeks before you experience any mood elevation or help from the antidepressant, if you're within that whatever percentage of people about 60 to 70% of the people who are eventually helped by some antidepressant drugs. It takes a while, and it takes less time the next time that you're put on it, but the very first time it takes more than 2 weeks. And the question is, or the assumption is, that the antidepressant drugs are affecting neurotrophins. So in depressed people, the particular neurotrophin, brain-derived neurotrophic factor, is low. And we've talked about neurotrophins before when we talked about brain development, but brain-derived neurotrophic factor is specifically allows us to keep those neurons alive that are being produced through neurogenesis. And we see this is specifically or particularly important in the hippocampus, where there is still a great deal of neurogenesis as we age. And so what we see, if you've noticed, in people who are depressed are smaller hippocampi. So it looks like this is a pretty good idea of how antidepressant drugs and those changes in the neurotransmitters are, in the longer run, affecting the brain, and what's actually helping people with their depression is to raise the brain-derived neurotrophic factor. Because what we're seeing in people with depression are smaller hippocampus, impaired learning, and fewer new hippocampal neurons, or those neurons are not staying alive. And so this would be changing that. I'm going to just say a few things here. So BDNF facilitates new learning that builds new synapses and removes old ones. This explains why people may profit from cognitive therapies as well, which I'm going to talk about very briefly, I hope. And a few antidepressant drugs improve mood without demonstrable effects on BDNF. So it could be that antidepressants are working in more than one way. So I'm going to take a step back and talk about the etiology of depression, which to some extent is what I've been talking about all along, except I stayed on really biological factors. And let's talk about cognitive factors. Some of this is not in the book, but I think it's important for understanding that people get to being depressed for various reasons, and there are different pathways to depression. One of the people who's looked a great deal into cognitive aspects of major depressive disorder is Aaron Beck. And he came up with a couple of ideas that are pretty important for understanding maladaptive thinking in people who are depressed. One is the negative cognitive triad. So people who are depressed tend to have negative thinking about themselves, about their situations, and about their future. I'm going to do this very colloquially because I think it expresses the basic idea. So people saying, I suck, my situation sucks, and my future's going to suck. It's bound to suck. Okay, so that's the negative cognitive triad. He also sees that a lot of times people who are depressed have a certain faulty logic. And in some classes, we talk about an internal locus of control versus an external locus of control, where an internal locus of control is my taking responsibility for where I am in my life, that I made decisions and I made mistakes, or I did good things, and I was the one who got me to where I am today. An external locus of control really puts that locus of control outside of oneself, where one might say something like, it's the people you know, it's the situation you're in, it's the powers that be, something else is controlling where I go in life. People who are depressed tend to have this logic of they have an internal locus of control for the negative aspects of their life. So when I do something wrong, when I lose my job, when I make a mistake, I'm saying I made a mistake. I did something wrong. I was the one who was at fault for losing my job or getting an F on this paper or this test or whatever. People with depression also tend to have an external locus of control for positive aspects of their life. So I get an A on a test and I say, well, that's because the teacher grades easier. This was an easy class, or that was easy material. Or I get a new job and I say, that's because of I was lucky. Or it was the people I knew. It had nothing to do with my talents and abilities. So you can see the kind of faulty logic here, where they're kind of beating themselves up for the negative aspects and not giving themselves their due for the positive aspects. Another cognitive factor is learned helplessness. So we see that animals who are in this situation where they're yoked to another animal, and the other animal has the power of stopping a shock. So both animals are being shocked, and one animal, I remember the dogs, they can like move their head up and to the left, and they can stop the shock. And those dogs learn to move their head up and to the left. But the dogs that are yoked to them, they're just receiving shock, and no matter what they do, they have no explanation for the shock, and there's nothing they specifically do to change that shock happening to them. And so they basically learn to be helpless, and we can put them in a whole new situation where they're in a crate and they could potentially jump to another side of the crate to get away from the shock at their feet. But those dogs who learned helplessness, who were yoked and didn't have any control, they are much more likely to just cower and whine and cry and to not jump to the safe side. And we see with animals that as they're learning, as rats and mice learn helplessness, as they have uncontrollable shock, we see changes in serotonin levels. We see the same kinds of changes that we see in a human brain of people who are depressed. And another piece of this is really the situational components, that there are often interpersonal roots of our relationships with other people and how we are relating to other people, as well as precipitating stress. As I said, that first episode of depression, we usually can see the trigger, the precipitating stress, and there usually is some precipitating stress to major depressive disorder.